Team, my name is Francis. I'm one of the internal medicine trainees at Sheffield Teaching Hospitals. So this presentation is on two new drug treatments that we introduced for treating IgA nephropathy. So IgA nephropathy is the most common form of glomerulonephritis worldwide, and this is driven by a mutation in galactose deficient IgA1 immune complexes, and then these gets deposited in the kidneys, in the mesenchyme of the kidneys. And roughly 40% of these patients, they progress into kidney failure within the next 20 years. So the aim of these drugs is to prevent them from progressing into end-stage renal disease. So the new drugs that we introduced are targeted release budesonide, which is called Kinpeygo. That's the commonest brand name, and sparsentan, which is a dual endothelin angiotensin receptor antagonist. And um, I'll show you some data of why these drugs are important. So this is the first drug, which is the targeted release budesonide. The efficacy was proved in a trial called NEF IGA trial, which is a double-blinded placebo-controlled trial. And what they did is they took patients who are already established on the conventional treatment for IgA nephropathy, which is RAS inhibition and SGLT2 inhibition. And on these patients, they tried the new drug plus the control group was given the placebo. And they followed them up in 15 months, and they observed that the proteinuria fell by 27% in the control group. And in 12 months, it actually fell by 48%. At the 2-year primary endpoint, it actually showed a reduction of the reduction of rate of progression of EGFR by 5 per year. And also the side effects, some side effects were noted in the Kinpeygo group, mostly hypertension because it's a steroid-based preparation. The next drug, which is sparsentan, it acts very similar to RAS inhibition. So the trial, Protect trial, it compared sparsentan with irbesartan. And actually, um, in this trial, about 48.8% patients on sparsentan had significant fall in their proteinuria compared to 15.1% patients in the irbesartan group. So there was a 41% relative reduction of proteinuria in this sparsentan cohort compared to the comparator cohort. And the EGFR slope was significantly slower, and the composite kidney failure endpoint, 40% of EGFR drop was noted in the comparator, whereas only 9 to 13% was noted in the control group. Sparsentan also gave a small extra benefit of blood pressure reduction because it's similar to RAS inhibition. So we did an audit on population in IgA population that comes to under Sheffield, so that we actually looked for if patients are actually eligible for this new treatments, and we evaluated. So those patients who are not getting this treatment, we evaluated why they are not getting the treatment, and is there something that we can fix in terms of service provision or any other factors. So um, in the trial that we did, we reviewed every biopsy confirmed IgA nephropathy patient in our center and classified anyone not eligible for therapy into 4 groups, which is whether they had a valid clinical reason, which is side effects to the drugs or any allergies to the drugs, and some with other reasons, which were treatment break in treatment or acute flare up of the disease. And some patients had service gap, which is waiting for clinic appointments or waiting for drugs to be approved or drugs to be dispensed. And some patients, we didn't actually find a reason why they are not on those drugs, but they should have been on those drugs. So we have a total of 358 patients. That's our total IgA cohort, and among them, 65% is male patients, which is typical for the IgA population. And um, and 38 38% of these IGA cohort was already established on renal replacement therapy, and most of them had transplant as a form of renal replacement. Some of them were on hemodialysis, and some of them were a very small population was on peritoneal dialysis. And within the cohort, a prerequisite for eligibility, 71% were established on RAS inhibitors, and 46% was established on SGLT2 inhibitor. And 41 patients were eligible for budesonide, and only 8 patients were receiving the drug, which is about 20% of the total eligible population. Similarly, and the reason for um, missing out on these treatments were established, and about 12%, 21% was not receiving the treatment because of clinical reasons. 7%, about 40% were actually actionable gaps. So there was either service gaps or missed appointments. Similarly, in the sparsentan cohort, we had 217 patients. Among them, 45 patients were eligible, and only 17 patients were actually treated with these new drugs. And similar to the other one, most of the gap is actually fixable. So it's either service gap or it's actionable gap. This is a combination of the previous two slides, and in this, about more than 50% of these patient cohorts with who are not receiving the treatment, it's actually fixable from our end. Right. So we devised a plan for fixing these treatment gaps. So what we did is we introduced one virtual MDT setup so that anyone can attend the MDT from anywhere, and it can mitigate some of the problems. And we introduced a nurse-led clinic wherein patients can come in. The nurses can do an assessment and see if they are eligible for these drugs. And if they are eligible for these drugs and if they meet the criteria, then the nurses can prescribe these drugs. So which would eliminate the need for clinician appointment. It would eliminate the need for physically coming into the hospital multiple times. And we can even outsource this into the community and reduce the treatment gap. And these are few drugs which might come shortly in the future, and there are good research going on, but not yet licensed for the use in IgA nephropathy. Right. So in a nutshell, we have a big cohort of IgA nephropathy patients, and most of these patients are now eligible for disease modifying treatment. But there are due to issues like service gaps and missed clinic appointments, the majority of these patients are not actually receiving these drugs in the real world trial that we conducted. So we devised a plan for these eligible patients to be actually receiving these drugs in the form of nurse-led clinics and virtual MDTs rather than waiting for clinic appointments. So that's the end of my presentation. Thank you so much.